All right, it's 2:03, January 10th, 2023. It seems far away from New Year's, but Happy New Year to everybody. Today we're gonna do SEVA VentRounds Express, and the title is Three Trigger Troubles. So let's get started. Well, we discussed particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. And here are my conflicts of interests, and also for Rob, and also Rob's conflicts of interest. So in case that you are interested on them. This is a recorded session, so we have a couple of rules that it's just keep your microphone muted. And if you want to make any comments, do them on the chat, or at times we will ask for some input. And if you want to unmute yourself, please go ahead. This is a safe environment. We want to hear everybody's input and learn from each other as we go through. Righty. So SEVA key knowledge is, there is a lot of nomenclature out there, and it's really confusing for the world to try to understand the literature. And actually, as you read the literature, you're going to end up reading so many definitions that sometimes you get confused about what is what, and we use words that don't mean the same. So last year we published an article in which we essentially followed some basic rules for taxonomy and created a classification for all patient ventilator interactions. And a key knowledge is to understand what this means, and to make it clear, the reference for any patient ventilator interaction is the patient. In this slide, we represent it as PMOS, but you don't always have the benefit of having here a little graph with red that says that this is the muscle or the patient. So we usually use what the deformations are on the flow or on the pressure waveform to see if there's evidence of PMOS. And in this case, it's a patient on pressure control. Each one of the breaths are on pressure control. And you can see on this one in which the patient effort starts, and I put a little gray line here to delineate where the patient effort started. The activity starts, I mean, there's always going to be a lag between the patient and the ventilator, but you see the lag, and then the ventilator triggers. You see some evidence of PMOS deforming the pressure waveform, and you can see the waveform has this, rather than a beautiful exponential decay, it has this concavity or convexity that it's occurring. And so that tells us that there is PMOS. And this would be what we call normal. The ventilator pressurizes relatively fast. When it's late, you can see the PMOS started here where this the gray line, and it takes a fair amount of time for the ventilator to achieve that. And actually, the pressure drops below PEEP, not below zero, but below what we would call baseline for a prolonged period of time, and then it triggers. And there's some measurements that you can do based on the industry, but this has not been very well regulated. But when you see a deep depression, you should consider that this could be a late trigger. It could also be just the amount of effort that the patient is having. In this one that is called early trigger, what you have is actually the ventilator triggers first, and then you see the activity of the patient. So the ventilator triggered first, so the ventilator triggered early in reference to the patient. And so this is called an early trigger. And one of the common, most famous causes right now is what's called a reverse trigger, although it can happen intermittently for other reasons. But reverse trigger is one of those. And what you see in the flow waveform, I mean, you can see here the deformation on the pressure waveform, but on the flow waveform, you can see it was nicely decaying. And then there is this increasing in flow over here. And then false trigger, you can see that there's no evidence of PMOS. So essentially the patient is not doing any effort, but the ventilator is identifying that there is triggering by the by the patient, and it's not the patient. In this case, it's a large leak, and that's why the flow is so high in this pressure control. And finally, failed trigger, in which what you have is actually the patient does do PMOS. So there's PMOS, and you can see the changes in flow and a little bit on the pressure, but it's not enough to cross the baseline and trigger another breath. So this is the patient failed to trigger the ventilator. In this one, the ventilator is falsely triggering, thinking that is the patient. So these are the 4 types of trigger troubles that you can have. So today we'll see a couple of them. All right. So that's a basic SEVA key knowledge. Late, early, false, and failed triggers. All righty. So in our classic now, we are in January, so majority of people have gone through the taxonomy. So what I would ask you is to put in the chat, what's the tag for the mode? And I left all the information on the screen so that you don't feel cheated. So the mode is up here. If you want to use the Vent Mode app to read it, or a card, or you want to read it out of it. Then we want to hear what's the load. So is it elastic, is it resistive, or is there presence of PMOS during inspiration and expiration? Any patient ventilator discordance. You will see that compared to 2022, we have changed and added or expanded what inspiration is to normal. If there is presence of over assistance, under assistance, or severe work shifting, so more to come on that. The cycle, is it normal, early, or late? And then if there is expiratory work. So go ahead, start filling your chat with your thoughts about this waveform. Have no fear. And I know for many, sometimes your comments, you're like, what the hell is this guy talking about? Don't worry, put whatever you feel it is. And if you don't know anything about the tag, don't put anything. We'll talk about it in around 1 minute. Come on, fellows, have no fear. Tap into the chat. Or unmute your microphone if you want to ask something. All righty, I see some. All right. So there's a good amount of people thinking that this is pressure control, and indeed, you're correct on thinking that this is the control variable is pressure control, and we know that because we can see the pressure is square waveform, and the flow is not controlled. So you can see 2 different flows immediately here. So that gives it away. In terms of the breath sequence, for those of you that don't know, I mean, here you could not make anything. You would probably say that this is CMB because the breaths are mandatory. They're triggered by the machine, and we'll see that in a second. But because it's on auto mode and it's highlighted here, I put that there. This is essentially IMB, so intermittent mandatory ventilation, and it's type 2, which means that when mandatory breaths appear, when spontaneous breaths appear, the mandatory breaths disappear, and it appears and disappears based on an algorithm that it's a little bit more advanced than what we're going to discuss today, but it's for you to understand that when the spontaneous breaths appear, the mandatory go away. And the targeting scheme, because this is pressure control and this is pressure support, it's essentially set point. So just as the fellows in the room and Ariel had outlined. So great job there. In terms of the load, remember that when you're looking at well, let's start by inspiration, and you have 2 different waveforms here for flow. So because you're controlling the pressure, you look at the flow. And if you look at this waveform here that says flow, at the end, it doesn't reach baseline, but you can see actually that there is evidence that the patient was taking a breath. So this is what we would call an early cycle, but because the patient didn't trigger the breath, then it means that there was PMOS here. And on the next one, you also see that there is a lack of the beautiful decay that you should have. So there's this little humpy that comes here, this area here. So that tells me that this patient is having PMOS, evidence of patient effort here where I'm putting the red line, and right here, that make me suspect that there, so during the inspiration there's load, and so I cannot really comment on if it's resistive or elastic. And during expiration, it seems to be decaying passively after this inspiratory effort here. It seems to go passively, and you could potentially think that this is resistive. So I would venture in saying that it's resistive, although it could be patient effort, but I will put resistive. In terms of discordance, as there's evidence of PMOS here where I put these red lines. And so if you talk about trigger, we know that this is a machine trigger breath. We know this is a machine trigger breath because we see that there is no change in color that this ventilator does when it's it interprets the ventilator, the patient doing it. And there's no deformation on the pressure or flow waveform that tells me that this patient actually triggered. But there's evidence after that mandatory breath of PMOS. So this is an early trigger as voiced by the team here, which in the literature currently the most common term is used is reverse trigger. Although reverse trigger has its own physiopathology per se, there's other causes that can cause this pattern. In inspiration, I would say that there is actually the breath is completely assisted throughout. There's evidence of assistance. The pressure never drops below or changes. And if anything, when there's early trigger, it's hard to talk about assistance because in reality the breath is out of sync with what you're aiming. So I would say that under these circumstances, if anything, I would call it normal because the ventilator is still. And then in terms of cycle, I know I mentioned here that this looks, and it is an early cycle, but one of the rules that we created for the taxonomy is if we call the first event, which is the presence of an early trigger, which is causing the early cycle. It doesn't mean that the patient has early cycle because this may lead you. Imagine if say that this patient has early cycle, it may lead somebody to increase the inspiratory time, thinking that they have to deal with that. And the problem is actually not the early cycle; it is the early trigger. And I don't see any evidence of expiratory work, so I would call it normal. So comments, concerns, thoughts? Roberto, you there?
No comment. Looks good.
So this patient, you can see that the team had tried. Actually, this is a common thing. The patient continued to have this level of desynchrony, and actually at times it would have a double trigger or multiple trigger. And you can see that the team had tried dropping the respiratory rate. The level of support was coming down on the patient, and we were managing this with sedation. And we dropped further the respiratory rate, and to us, a big part of this behavior on what we call reverse trigger, because each breath was having this, is a manifestation of the effect of sedatives and opiates in the respiratory centers of the medulla and the bulbar area. And so these, if you notice, when we dropped the rate on the patient all the way to 6, the patient started breathing on its own and triggering every single breath, and the reverse trigger went away. Evidently, this patient has other features that tells you that there's toxicity, very large breaths, low respiratory rate, but it took away this problem. And so with this, we essentially were able to, I mean, the patient is off sedatives, and we will just watch her because our goal is comfort, is mainly comfort, and we'll continue to walk down the PEEP. But now the patient is breathing on her own, exhaling passively, as you can see here. And it's still on the same mode, in auto mode, but now because we dropped the respiratory rate, we allow the algorithm to to come in and to do what it should. So even though the rate was relatively low down here, you can see that the patient was breathing at the same rate that was set on the machine. And so it took a further decrease on the respiratory rate to observe that. Now, sometimes that doesn't help and solve it, but and then you have to just tolerate while the patient comes out of the sedation effect, which can take hours and it can take days in general. Comments?
Yeah, I have a comment. Because this is auto mode, the way it functions is that if the patient makes inspiratory efforts, they will suppress the mandatory breaths. If there's no mandatory breaths, by definition, you cannot have early trigger.
Correct. Correct. The only reason that we left the auto mode, that's a great point, Rob, because the question was, well, put the patient on pressure support. But as the patient is emerging still from sedation, the concern is, well, then it starts activating, and this has to do also with behaviors on the team, right? So if they are in auto mode, no alarm will sound. They will go to their basic respiratory rate, and so to mandatory basal rate if there's apnea, and no alarm will sound. However, if you are, and so no changes will be on the ventilator. If you are on pressure support and somebody comes and changes sees that there's an apnea alarm and the patient goes for 20 seconds, 30 seconds, and then they will switch them back to a rate which will end up in the same behavior. And so it's a challenging situation at the bedside that unless somebody is aware of it, it doesn't. Ariel, you had a comment there. Can you comment on this, please? You have done a lot of work on auto mode.
Yes, the same case happened to me. Sometimes you need longer apnea times than auto mode, you can only set an apnea time from 7 to 12 seconds. So no more than that. And sometimes in order to, I would call reset the respiratory tribe, you need longer times. That's why I mentioned that a trial of pressure support could prevent the reverse triggering. And after that, you can go back to auto mode to give to meet the goal of safety at the same time.
Very good. Thank you, Ariel. Great comment. Any other thoughts, comments from the audience? All right. So here's another one. This is fresh out of this morning. You can, well, this evening, it's 23:01:09. This actually, that I just realized the date is wrong on the ventilator, but the time is correct. I took it a little bit while ago. While I was rounding, I was looking at a ventilator on my right side, and I saw this, and I thought I would bring it over. So please look at the screen, and it would be very interesting to hear your comments and thoughts on this patient. What's the tag? What's the load? And what's the PV discordance, patient ventilator discordance? Have no fear. There's no judgment or anger, just love and understanding. I'll give another minute. Have no fear. This is where you test yourself and see if you are reading waveforms as they should. All right. From the fellows room, I waiting for, there we go. All right, let's do this. Okay, so what's the tag? The tag is it's pressure control. Just as and that's because we see that the pressure is being controlled during the breath, and you can see that the flow, it's not controlled at all. It's actually pretty different between both of them. This is IMB, and we know that even though you only see one breath here, you would not be, if I just showed you this, you would not be able to determine that. But this helps you determine it because I left the commercial name here. And again, this is IMB type 2. But this one is a little bit different because it changes from, instead of pressure control to pressure support, this one changes from PRVC to volume support. And in that case, it's adaptive targeting, meaning that you set the tidal volume that you want down here, and the machine will move the pressure, the inspiratory pressure, up and down to achieve that target volume. And that's how it works. In terms of the load, this is a fantastic waveform. I mean, it's as high quality as it gets to read the physiology. So when you come in and you start seeing the waveform here, sorry, for pressure, you will see that there is absolutely no evidence of change here on the pressure. And the flow looks pretty flat also, but if you notice, it's below the baseline. So this patient is trying to, oh my God, sorry. So the flow is not reaching baseline. And actually, when you see the expiratory time on the baseline, you again see exactly the same thing. The flow is taking forever to get to baseline. So immediately, just by looking at that, you know that this patient in expiration has very high resistance. During inspiration, it's a little bit more tricky because you see the flow rises really rapidly. And then you see this instead of seeing the nice exponential decay that you should, you see this flow that you only see a little bit of it. And the breath is set at 0.7 seconds. And during that period of time, it barely decays. And on the second breath, you actually see a pretty aberrant form here of the flow waveform that could signify or be interpreted as the presence of PMOS. So during inspiration is hard, but just by looking at the amount of resistive load that it's on the expiratory, this makes me think that this is actually, because I don't see any evidence of PMOS during triggering, and there's no triggering here. The question is there evidence of PMOS behind this, or is there a very high resistance? So I'll put resistance versus PMOS. So I was standing in front of this ventilator for a while, and they were presenting me another patient, and my eye was looking at this ventilator. I was like, what's happening there? So as I looked at it, I said, well, the patient is not triggering the breath. And then you can see that as the first pressure, depressurizes, the breath ends, and it goes below baseline. And that could be a marker that the patient is doing effort. So that would go with what some of you mentioned as early trigger, because this is not a breath triggered by a patient. So this could be early trigger. And you see this drop, and then comes the second breath, which is a volume support breath. So this is a mandatory breath, and this is a spontaneous breath. So technically, if you want it just for your brain, this is a PRVC breath, and this is a volume support breath. And the algorithm, and just as a side comment for you, what I understand from being at the bedside, although it's not clearly defined on the manual to my eyes, is for the PRVC algorithm controls the mandatory breath, so it will give you the amount of pressure that it did for the last, based on the last mandatory breath, and it will give you the pressure for volume support based on the last spontaneous breath. And so you can see that for the spontaneous breaths, so for the volume support breaths, the ventilator is delivering much higher pressure. That's why you see two different pressures here. And it's doing that because it's not reaching the tidal volume target that was set for this patient. So if this happened again on the next one, the patient is going to get a much higher pressure because it's not the algorithm. So it's running two algorithms separately, which is crazy, but well. So I saw this, and my initial thought was that this was an early trigger. The patient was being weaned from sedation. And so then I noticed, just as I'm seeing that some people have put on the wave, that the trigger was on 1 liter per minute for flow. So you can see it's triggering by flow. And in this ventilator in particular, this can happen, which is a type of false trigger that happens because it's trying to overcome the very high resistance, and so it drops the flow, the pressure as fast as it can. And so what we did is we just changed the trigger to pressure, and this is the waveform that ensued immediately afterwards. And so you can still see the high resistance. You can see the absence of PMOS. I mean, you don't see any evidence of PMOS in the pressure or on the flow waveform. It actually, this is a manifestation of how high the resistive load is on the patient during inspiration. And this little spike here is probably from the circuit because it's using so much pressure. And then you see the resistance is humongous on this patient, and it's not reaching baseline throughout the breath. So this is a case of actually a false trigger that was creating a lot of issues with the team because obviously this was creating two breaths. You can see that this patient was getting 400 plus around 300, so 600 of tidal volume under these circumstances, and it was happening every single breath. So there's no evidence of PMOS, there's no evidence of cycle activity, and there's no evidence of expiratory work. So this is just false trigger. Thoughts, comments, Rob?
Yeah, about how big the tidal volume was, it's hard to tell. I don't think you're going to get 400 or 500 every breath, because when the second breath comes in, because it's pressure control, the pressure, the driving pressure is the airway pressure minus the pressure in the lungs, right? So the pressure in the lungs is still pretty high. You're not going to get the same size breath on the second one like you would if it was auto mode with volume control and volume support.
True. Although I think that because of the algorithm is going with this separate algorithm, it's going to continue to climb up the pressure to try to give you that tidal volume. So if I had to choose a mode in which this is happening, the double trigger, I would choose PRVC pressure support.
Yeah.
Sorry, PC pressure support. What do you think about that?
Yeah, probably.
Yeah.
Problem is you can't tell how much volume is being exhaled after those two breaths because the ventilator resets. The only way to know would be to put it on a simulator.
Yeah. So the next breath, you can see that at that point where we were, they were at 519. So I think that there is definitely I mean, the corollary here is that you have to recognize when you see this pattern, you may be inclined to increase sedation or paralysis, but this patient was having no PMOS. So, but sometimes you cannot recognize it from the ventilator waveform. And one of the techniques to do that is either to try to increase the amount of negative of the trigger threshold so that if there is evidence of PMOS, then it will become evident, because then the patient will be kind of locked out and you will be able to see it on the pressure waveform and say, oh, this is reverse trigger or this is false trigger. Thoughts? All right. Very good. Alrighty, so it's 2:32. I think that these two cases were pretty evident for you all. and they were teaching for me. I mean, this was high quality. I will just leave you with this image for you to recognize the third type of trigger trouble, which is this one over here that you can see actually with correlating with a change in pressure and a change in flow approaching the baseline, which is a manifestation of a failed trigger. And we can talk more about this as we talk more about assistance, over assistance, auto PEEP and whatnot. Very good. With that, I leave you. Please send us your waveforms. We really welcome waveforms from anybody so that we can discuss here at VentRounds. And thank you for your time and Happy New Year to all.